can help you with all. What are the types? How many types are there? What did you read? What was the text? Variant. Take it here now. Type 1 and type 2. What is type 1? What is type 2?
Single.
Where the doctor? What the doctor? No, you can. Yeah, probably you will know how. You can help. Itu berapa partners now there? Huh?
जिंदगी ना
What is type 1? What is type 2? What is type 3 also? Type 1 is polymicrobia, type 2 is monomicrobia. So monomicrobia can be positive, negative, anaerobic, aerobic. Who are the people who are at the risk of type 1? Example? Like that. Who are the people who get type 2? Those who are healthy, young adults. Even you can get type 2. So what do you think? What is the reason for type 2 infection? Huh? No, it is even following severe trauma, I agree. So what is the, because of what? Host is good. Yeah, the organism will relax. Type 1 is, organism, host defense is not good. So you can get multiple polymicrobia. So type 2 is mainly due to organism. What is the organism for type 2? Group A, beta hemolytic streptococcus. Example? What is type 3? Type 3?
Yes.
Gas gangrene. What is the other name for gas gangrene? Clostridial myonecrosis. The difference between these two and this is this one goes beyond the deep fascia into the muscle compartment. What is organism? Gas gangrene. Clostridium. What is the other name? Clostridium welchi. Two names. I'll ask a different question from you. Tell me surgically important Clostridia. Name 5 surgically important Clostridia. Only Duranjana can answer. Duranjana. Clostridium botulism. Botulinum. Okay. Why? What is the surgical important? When do we use that toxin? When do we use that toxin? For cosmetic reason. For anti-aging, wrinkling of the skin. Anything else? For achalasia cardia. Okay. Anything else? Any other Clostridia? Like make here Clostridium perfringens. Importance is gas gangrene. Clostridium myonecrosis. 2, 3. Difficile. What is important? Pseudomembranous colitis. 3, 4. What is Clostridium? Tetanus. 3, 4. Okay, yes. අපි ඉන්නවා ඉවරයා ඒවත් දරගන්න ඕනේ Clostridium septicum කියලා එකක් ඉන්නවා. It's another one can cause gas gangrene. If you get Clostridium septicum gas gangrene, you have to exclude bowel cancer of that patient or leukemia of that patient. Very rare condition. Even if you don't remember that, I don't mind. There's another one called Clostridium histolyticum. That toxin is used for deputant contractures. Injections are used for deputant Clostridium histolyticum. Those are other Clostridia. Okay, coming back to Krishani's discussion, or rather my discussion. So we know the types, we know the organisms, we know the susceptible people. What are the clinical features? How do they present?
Severe pain
Evidence of extensive tissue necrosis. Remember, sometimes they come up with severe pain only initially. When you examine the skin looks perfectly normal. In a diabetic patient, complains of undue pain over lower limb, some area, let's say thigh or leg, and the patient has features of sepsis, you have to be very, very alert. Because pain could be an initial presentation. But next day when you look at the patient, there's extensive skin necrosis. So that's one person in pain. The other one is extensive tissue necrosis with blistering cellulitis. What is the color of the blister fluid generally? It's dark red or blackish fluid. Dark red or blackish fluid, you have to suspect. Generally, blistering cellulitis, they have a straw color fluid. If you see dark red and blackish fluid, you have to suspect. Anything else? Yeah, crepitus in which? In gas gangrene, yes. Other things, no. But gas gangrene, who are the people who are susceptible? Where do you get this Clostridium from? The soil. Any contaminated wounds. Generally, they say it's farmyard injuries and or casualties. Right? Those are the classical, but any contaminated wound can get this. Soil contamination. Because the spores are in the soil. It's an obligatory analog. Right. Okay, so then, you said pain, you said extensive tissue necrosis, blistering cellulitis, what are? All these are local. Systemic. Patient can be septic with or without organ failure. ARDS, AKI, anything. So that's how we answer local and systemic. Clinical features. How do you investigate? What you should state to start? It is a clinical diagnosis. Clinical diagnosis. Investigations are needed to detect the complications of the disease. So you have to do your inflammatory markers. If there are organ failures, do the relevant investigations. But diagnose this per se. I mean, if there's a wound, you can take a wound swab. Otherwise, during debridement, you can take tissue culture image. Otherwise, nothing. X-ray, CT, those things are limited value. X-ray, if you suspect underlying osteomyelitis, yes, but otherwise, no. So, in clinical diagnosis, all the investigations are to exclude or confirm the presence or absence of organ failure or complications of the disease process. How do you treat? To start with, I told you it's a surgical emergency. So, after initial resuscitation, you got to wound toilet. Wound toilet is not a good term. Wound debridement. Wound debridement. So, tell me your initial resuscitation if you get the house of a patient coming with a blistering cellulitis. When you examine the color fluid, patient is shivering. The patient also says, that's a scenario. You are the house officer.
Diagnose the patient is dehydrated. You start fluid resuscitation. With adequate fluid resuscitation, you can catheterize the patient and measure the urine output. According to the urine output, you can change your resuscitation. And then you can start give analgesics. And after taking a bone swab,
Shall we start differently? I will assess the hemodynamic stability of the patient. Check blood pressure, pulse rate. You will not put in Dausapura and then I'm keeping patient can be septic and hypotensive also. You are worried about urine output, right? So check the hemodynamic parameters of the patient. It can be ARDS, everything, right? So figure that out. Check pulse rate, blood pressure, organ saturation, check the lung disease also, and then like you can't usually you don't put the patient acute side bed, maybe first bed of the wound side. You can take the patient there and then what? Put IV cannula. This is the day. IV cannula. Take blood for investigation at the same time, namely
full blood count, CRP, blood culture, and
why do you say blood for culture and ABST? Because I told patient is sugar, chills. Okay.
and renal function test.
Okay, basic investigation. Then you can take also INR. Sometimes they have coagulopathy also, DIC. So take INR. So then, as you said, hydrate the patient and catheterize and monitor input out. What else? Analgesic if the patient is in pain. What else? And if food, I will ask you and also as the patient has low urine output and I don't have the basic renal function, but I will make sure that I will avoid all the necrotoxic medications. Otherwise, for pain, you prescribe diclofenac supposedly over diclofenac, and next day creatinine comes as 265. You are pushing the patient to take AI, right? Because I don't know that you not put adu. I'm really alert now. I'm not going to give any necrotoxic medication. So those things should be told at the exam. I can't get the regular part because you know these things. It's just a matter of putting everything at the exam. One more important thing. Forgot how they are doing that.
After taking blood culture and
I will start. You can start here again. But for exam, you can start
the patient
If the patient is a diabetic patient, you are suspecting polymicrobial type 1, what will you start? I will start antibiotic with positive, negative, anaerobic coverage. I will start metronidazole anaerobic coverage. I will start penicillin for positive coverage, ciprofloxacin negative coverage. It all depends on antibiotic policy of the area. Just that you have to show the examiner I am covering a positive, negative. Don't start meropenem from one side. Examiners will be like, you are going to start meropenem. How much will it cost? Blah, blah, blah. Meropenem, when we were HOs and registrars, meropenem cannot be started by HOs or 2-3 years back. I think it should be like that. In other country, in European country, only microbiologists can change the antibiotics. Surgeons can't. Physicians can't. I think it should be the way. වැඩිදී සමහර මයික්‍රෝවයිස් පටන් ගන්න දවස් 14ක් විතර දෙන්න කියන. ඒතර ඉතින් අපිට ලෙඩ තියා ගන්න බෑ. Okay, so positive, negatives and anaerobes. If he comes with the necrotizing fasciitis, you assume that he is not immunocompromised. He has not created any bed bugs or anything. He's just very obedient, nice, well-behaved boy coming with a wound with necrotizing fasciitis. What is your suspected organism now? Beta receptor. So then we start. Again, penicillin is enough. Right? Penicillin is enough. So Clostridium perfringens, penicillin, clindamycin. Clindamycin, remember clindamycin is a penicillin group drug. It has a very good bone and soft tissue coverage. It's a very good drug for bone and soft tissue, osteomyelitis, and also for bones, soft tissue infection. Clindamycin. It is not renotoxic, it is hepatotoxic. You can start IV 300 8 hourly. You can go up to 600 8 hourly, but to make sure liver functions are alright. It's a very good drug, the bone and soft. So you can start penicillin for type 2 as well as for Clostridium perfectly. Right. So that is your management, and they resuscitate, do all these things and prepare the patient for surgical debridement under general anesthesia or regional anesthesia. So that's why you need to do INR and all, because if you want to do spinal, you have to make sure that patient has no coagulopathy. Otherwise, for coagulopathic patient, if you do a spinal, there is a spinal hematoma. Why they ask for INR in spinal patients, for spinal in septic patients. Right. So in debridement, remember, it is a how can I say? You can't just do one wound toilet and finish it off. So all what you do in first wound toilet is you remove all the necrotic tissue. You don't think about how much you lose. If it is dead, you have to remove it because it is the nidus for infection and you are going to compromise the patient's life. So you have to remove all the dead tissues until it bleeds. I'll show you that wound tomorrow. You'll be surprised how much they have removed it. Huh? So they just remove all the dead tissue. We are not worried about it, but we need to cut out to bleeding edges. Although we cut out to bleeding edges, if you inspect the wound tomorrow, there will be another area where it is necrosis. So you might have to do repeat wound trials. So it's an emergency. That's a surgical emergency. It's an urgent surgery, actually not emergency. You resuscitate and take the patient to theatre and do debridement. Wound inspection daily, needs repeat wound debridement. Once the patient is settled, wound healed, everything, you think about the reconstruction. You don't worry about reconstruction now. Later you can put a flap or a graft or whatever. Reconstruction, you think about it. So that is, if I ask you to write a short note, that's how you should write. Definition, types, susceptible people, clinical features, how do you investigate, how do you manage. Those are the key topics. In addition to this, for type 3, that is Clostridium perfringens, gas gangrene, Clostridium myonecrosis, needs something else. They need wound toilet, they need a massive wound toilet, you have to remove all dead muscles as well. There's a place for hyperbaric oxygen therapy. Why? They are obligatory anaerobes. Therefore you need hyperbaric oxygen. You can give hyperbaric oxygen. And depending on the site, the name changes. If you get necrotizing fascitis in the external genital, you call it Cooney's gangrene. What are the causes of Cooney's gangrene? So usually type 1, gangrene. What are the causes? Maybe ILD lapses, cystoscopy, catheterization, because even a simpler procedure can give rise to infection in the perineal region, right? And Cooney's gangrene. Again, emergency debridement. Sometimes we have to remove entire scrotum. The testis is generally preserved. You can later put a skin graft over it, or you can just make a pocket in the inner thigh and just internalize it. Right? It doesn't have scrotum, but testes are there. The function will remain the same. Okay. So read about it. Write a short note. I need to see the short note tomorrow. Leave in a short note. Here we go. Little mother kid in naked there, no? Live on our mother kid. You are like kids. And I'm making another make a man adults are yes, Samu. Yem Balam. Yem. Better perhaps.
Rectal prolapse in simple terms, it is the portion of the rectum outside the anus. It is mainly of two categories. Mucosal prolapse and the full thickness prolapse. when we first talk about the mucosal prolapse. Mucosal prolapse is when the mucosa and the submucosa of the rectum protrudes outside the anus. We can identify it by palpating, where we can find out it is just a double layer of mucosa, nothing else. When it comes to full thickness prolapse, all the muscle layers of the rectum comes outside the anus, and by palpating it, we can feel the thickness is much more than the mucosal prolapse. In mucosal prolapse, it is usually around 4 centimeters.
What is this? Which prolapse? The full thickness rectal prolapse. You are here with 22nd batch. 22nd batch check out.
Full thickness prolapse is usually associated with a weak pelvic floor, and at the same time it is roughly around, it can go up to even 10 centimeters of length. And mucosa, when we talk about...
It's always or mostly due to the pelvic floor weakness. When a patient comes with rectal prolapse, don't suspect anything bad about that patient. Now there's a young patient rectal prolapse. Don't think, maruge, deela tama anus ekata lax wennama kiyala. There's nothing like that. It's a pelvic floor weakness. Just because somebody engaging in anal intercourse daily and you don't do rectal prolapse. Okay? Aruge waparahen balanna epa. Harida. Waparahen balanna epa. Eke pelvic floor weakness agane even you all can get it someday. Hope and pray that you will not get it. Well, සමහරට pray කරන්න ඉඩ තියෙනවා මේ අනිතිය. Yes.
When it comes to mucosal prolapse, the predisposing factors differ according to the age group. For example, in infants it could be due to underdeveloped sacral curvature, while in adults it might be due to third-degree hemorrhoids. And full thickness prolapse, we might need to differentiate between intersusception and prolapse.
So the differentials are, as she said, intersusception and rectal prolapse. How do you differentiate?
When we examine intersusception, we can insert the finger in between the prolapse.
What you do is you take a tongue depressor generally, right? So you can pass the tongue depressor between the anal verge and the protruded tissue mass. So if you can pass, if there's a space in between, it is intersusception. If there's no space between anal verge, like picture, there's a space between these two, it's intersusception. But if there's no space between anal verge and the prolapse, it's a rectal prolapse. Okay, treatment.
For mucosal prolapse, we first go with digital
Reposition. Digital manual reposition.
Second option is injections with 5% phenol and olive oil.
You digital reposition it and then inject submucosal phenol to get it fibrosed.
Third option is surgery by suturing the rectum.
So remove the excision redundant mucosa, mucopexy. Okay. For rectal prolapse, full thickness, what are the options?
Could be abdominal perineal approach.
Do the perineal
The
approach.
patient is elderly, we prefer the perineal approach.
Why? It has low complications, less complication, but more recurrence. So if the patient is elderly, if you don't think of recurrence rate, let's say 85-year-old Archie comes with this, you don't prefer abdominal surgery, you go to a perineal approach. There was a patient admitted in your rectal prolapse. Was it done? Professor Deepaka will say that's the large goiter. It was postponed. Use on clopidogrel. So that is, what are the perineal approach? What is the name? What are the names? Delomes. I don't think you know to remember it. There are perineal approaches. One is delomes, the other one called alchemia. There are so many. Just forget about the names. So remember perineal approach. It has high recurrence but low complications. Whereas abdominal approach has more complications compared to perineal, but recurrence rate is quite low. What are the abdominal approaches? What are the abdominal surgeries? It can be open or laparoscopic. So what you do is, it is a prolapse rectum. You pull the rectum up and anchor it to the sacrum. That is called rectopexy. Rectopexy. You can do open abdominal rectopexy or laparoscopic abdominal rectopexy. Fixation can be done by two means. You can put a mesh and anchor it, or you can put a suture and anchor it. Suture rectopexy or mesh rectopexy. Complications are, if you anchor it, අප ජීවිතවලත් යන්න බැරි වෙන්නේ අත්තරම යට ගන්නවා. ඒතර මොකද rectum එක angulate කරලා constipation. ගොඩක්ම tight උඩටම ඇද්දොත්. That's one problem. Constipation. And when you catch with sutures, you can catch also the ureters. That is another problem. The other one is, when you dissect in this plane, there are hypogastric nerves. Especially if you do this surgery, this guy. There's a young chap awaiting rectopexy. What is the main problem? That is the main problem that you are worried about? Impotence. Yeah, if you damage the hypogastric nerves, there is a possibility of impotence. So you are very careful not to damage the hypogastric nerves when you dissect along this plane. So those are the complications. Some over. She also, at least, she has read it. I expected you to write a short note. Then you will remember. Not for me, it's for you. If you can talk 5 minutes on rectopexy, that's it. So when you study everything. Because with time, it decays. Your knowledge decays. It's a natural process. It applies to you and me and Aloka sir and Deepak sir, all the professors, to everyone. So start with 100%. With time, it decays. Exam 0, minus 10 or so. Depends. But always aim for stars. Don't aim for just pass. Aim for stars. පොල් ගහ කරලා දෙබලක හරි දෙබල නෑනේ පොල් ගස්සට අර මේකක හරි රැඳලා අතර මේ අනස්සක හරි එල්ලලා ඉන්නේ නේද පල්ලෙහා ඉන්න ආපුරම් පැටි දිනා කියලා කියනවා